So, welcome back to Outside the Box, our EMS podcast to drive clinical performance. We have a special guest with us today as we talk about some clinical topics. And Jay Barrera is the training chief up at ESD 48, responsible for driving their clinical performance and practice. Welcome, Jay.
Thank you. It's nice to be here.
So, why don't you tell us about you, some of your experience, your background, and help us get to know you a little bit.
All right. Well, I got into EMS in 2005. I tripped into it because I needed first aid training for a camp that I run. And every time I sign up for a class, it'd get canceled. So I finally took an EMT class that the local volunteer fire department offered. And then I thought, well, I'll make a few bucks on the side. And now we're in 2023, and somehow I ended up making a career out of this thing. So it's been pretty interesting.
Fantastic.
So, yeah.
Well, I like it because you and I got to meet each other through
Yes.
this career. So I'm not complaining about it anyway.
I got very few complaints, if any. So not about knowing you, just about, EMS. But so I've been doing it however many years that is, almost 18 years, I guess now. Was an EMT for a couple years. Went on straight through to get my paramedic. I took a fast track class. Don't recommend it. A lot of information to come at you in 6 weeks. So basically I had to read 2 different paramedic textbooks to get my paramedic, and then decided to work. We were West I-10, but I was with Austin County EMS first. Got my feet wet there, moved on to West I-10 Fire Department, and then they transitioned into ESD 48 and became FTO with them, and then moved on. My predecessor moved to another department, and I finished my degree finally at 49 years of age, and then put in for that position, and I've been doing that for the last 2 years, starting 3 years in March.
Well, there you go. Very nice.
So,
excellent.
yeah.
So, full disclosure, Jay and I do go back a little bit and have a little bit of history.
Yeah.
And that's why I was really excited to bring him on here, because these are the discussions that you and I would have on a regular basis.
Yeah.
That we'd bring these kind of topics up, we'd pick them apart. And this is a fantastic demonstration of how we want this information to come across to the field when we discuss these topics.
Right.
So today we're talking about PEEP. We're talking about PEEP. So
PEEP.
You have experience with PEEP.
I have some experience with PEEP.
Nice. And handful of devices to generate PEEP that you've used?
Yes. Obviously, it started off with the PEEP valve on a BVM. So obviously PEEP standing for positive end expiratory pressure. But you throw that out there. I'm not the guy that, I'm not a big word guy. I'm very much down in the dirt and tell me what it means. And I'm a visual learner. So if I can't, grasp that what it actually does, it's harder for me to remember and learn it. And so I literally had to break down positive. Okay, so that's a plus, right? End, so it's at the end of something. Expiratory, okay, I'm breathing out. And then obviously pressure. So it's what's left over after I've exhaled. And that's how I kind of had to remember that. But then when the first time I ever saw it, I had a brief stint at Fayette County EMS, and the clinical manager there was showing us a rescue pod. And so he put it on and he squeezed it, and I got to see how PEEP actually worked on that. And I was like, oh, now I get it. And so from there, it just, then we got the PEEP valves we put on the BVMs, and then of course we use it on our event. We use the Z-Vent at our department. So it's a very interesting but yet very necessary tool in managing airway and ventilation. So
right, and as we talk about it today, we're not talking about any one specific modality.
No.
We'll talk about it in CPAP with intrinsic ventilations. We'll talk about it with mechanical ventilations, and kind of the principles carry across the board. It's just, am I producing my own ventilations, or are you producing my ventilations for me? But so all these things,
or are we helping each other out?
Maybe we're doing both,
Yeah.
right? We are. So we get the ventilator in there. We have some of those settings, and something you can look forward to as we come up through the summer. So we talked about how you grasped onto PEEP and how you learned it. Have you heard any other peculiar, interesting ways to explain the concept of PEEP throughout your years?
I was thinking about that, and I haven't really had something that's just been so far out there. Most of the time I've been exposed to it, it's been a very, that clinical talk that seems to be high if you're not following it. And, that's where I have to kind of, I'll make a note to myself and be like, okay, look this up, Google this later or whatever. I've gone through YouTube videos discussing it. I've gone through different classes. And once you kind of get that grasp, it's pretty simple. And so to answer your question, no, I haven't really found anything just really odd and out there, but I've found a lot of cool ways that people have shown it. The biggest one is with the balloon and a BVM.
Yeah.
And then I kind of stole that idea because, nothing's really sacred, and, we take what we can use. And so I actually use that when I talk about drownings and even talk about like washing out surfactant. You fill up that balloon with water and you dump it all out, how it sticks together, and then you can really show PEEP work well with that. And so, the little things like that, little examples like that is what I've seen the most. And it's probably because I'm not looking for the odd way to describe it. I'm looking at it just like, how can I understand it and then explain it to somebody that may not know.
Yeah. I like the balloon one. I like using that one too, that first blow, and then it starts to get a little bit easier.
Right.
When we're talking about the alveolar recruitment and getting the alveoli engaged, right? But I had the thought not long ago that PEEP's essentially a yawn, right? Like you go to yawn in your chest walls pulling open, increasing the pressure gradient, more negative pressure in to pull air in. And really that's what we're doing is kind of stretching alveoli, increasing that surface wall to exchange gas.
That's a good point. I hadn't thought about it that way.
And right, I mean, you yawn randomly throughout the day, and you may not even be tired.
Of course, now you've mentioned yawn, so I may end up yawning.
You probably will.
Don't take it personal.
Okay. So, right, but that's all we're really trying to do with PEEP is get the alveoli open, or stretch them out. Right, we talk about a whole lot of different things about, especially with pulmonary edema or drowning, like you're talking about, that we have water in that space. We're not necessarily displacing the water. It's all about stretching the alveoli, right? So I like the balloon one. I like talking about the yawns. And like you're talking about these demonstrations, the best one I've seen is, it's another YouTube video, but it's a cadaver lung. That you see the lungs inflated, they're held open with this cracked chest.
Right.
And then you take this PEEP valve off and there goes all of that.
All goes down.
Inflation.
We actually made one of our own for that very reason in our last cadaver dive, and we have it. I actually use it in my, I have a pediatric drowning talk where I use that because to me, nothing shows you more what it does until you have a chest open and you're seeing the lungs work.
We'll have to get a hold of that too, and we'll pass it around.
I'll send it to you.
So absolutely. Right. So PEEP, we use it to increase oxygenation, right? Like we talked about, and we alluded to it a little bit, that we increase the space that we exchange gas.
Right.
But there's two mechanisms that increase oxygenation in the body, right? There's the volume and there's the pressure, and CPAP kind of plays on both of them, which is peculiar because it's not a ventilatory technique.
Right. So,
pulling out some of the literature we talked about, this is where we get kind of fun and brainy here, that alveolar recruitment, opening the alveoli, happens during inspiration, when we inhale, right?
Right.
But we're talking about the end expiratory positive pressure. So we're manipulating the inspiratory mechanisms with an expiratory process to produce high volume and high pressure oxygenation into this bloodstream. So, I like thinking about these things a little bit deeper. You know me, I'm a nerd. Like we just say, hey, it keeps pressure in the lungs and it makes it easier to do these things. And that might be good enough. But again, I like taking it a step further. This is this recruitment, this inspiratory phenomenon that we're capitalizing on, we're producing. So, and that's where we get those. I'm sure you've had plenty of them too, that you get the respiratory distress patient, you get that pulmonary edema, and you're like, is CPAP going to work? It's one of those, it's going to or it's not. Let's try putting it on the patient. We caught them, turned them around. Okay, great. And you get the ones, you put it on, and 4 breaths later, they're starting to nod, and it's okay.
Right.
That's the way this one goes. All right. So if the inspiration's not there to produce the start of the recruitment, we can't enhance the recruitment.
Correct.
So that's the fun one with CPAP, right? That we need to have those pieces together. So,
and CPAP's an interesting thing just on its own because, I mean, it's in the name, right? Continuous positive air pressure. So you're just constantly throwing air, throwing oxygen, and hoping that in a sense, sticks. And until you've been on CPAP and you can't exhale to get to that end, that's a whole nother issue. And that's why it's very important for us to monitor that pressure, to monitor that PEEP, because you got to be able to breathe out to get to the end.
Absolutely. And that's a fantastic segue into the discussion of managing a VQ mismatch with CPAP and how, what a challenge that we're dealing with. That it's one thing to have pulmonary edema or even pneumonia,
Right.
lung full of junk, put this pressure on there, open the alveoli, we increase the oxygenation, but we're missing half of the ventilatory cycle, like
Right.
you mentioned, right? And a lot of times we talk about respiratory management, airway management, talk about our goals to oxygenate and ventilate.
Mhm.
And you know me, words matter.
Words
Semantics
do
are
matter.
important.
Yes.
So I'm going to say we take ventilation out of there. We kind of replace it with elimination, because ultimately that's what ventilation is, right? I mean, we talk about minute volume and eliminating waste as we measure
Right.
rate and tidal volumes. So if we focus on oxygenation, that's pretty specific, but
Mhm.
ventilation is kind of broad. So we need to
Right.
get on the same level of specificity. So CPAP doesn't help us with elimination.
No, not at all.
So let's go back to the drowning, because I know
Okay.
you've done quite a bit of preparation research, especially with the pediatrics. And unfortunately, drowning season is going to be coming up here pretty quickly.
Oh, yes.
And that is one of the most classic examples of a VQ mismatch that
Mhm.
we could come across. And I think it's a really good dramatic demonstration of a VQ mismatch.
Right.
So before we dive too deep, help us understand a ventilation perfusion mismatch and how drowning itself is going to put us in this VQ mismatch situation.
So obviously VQ mismatch, V is your ventilation. The Q is your circulation.
Mhm.
So, and I saw a great diagram of it one time, and they've got the blood flow coming in. The idea is it's going to your lungs, and you've got one small, very narrow, we'll call it the capillary, and then you've got a wider one as well. And the wider one signifies the circulation. There's plenty of circulation there moving by. Up top, there's plenty of ventilation coming in, but you're just not getting that circulation to carry those gases, that gas exchange. And so when you look at causes, obviously in a drowning, you've got a liquid medium that's come in there and has blocked your ability to ventilate that patient. Your circulation hasn't been interrupted, so to speak. Obviously, the child or the drowning victim may have arrested. Obviously, there your circulation's been interrupted. But let's just, for argument's sake, say they're still able to try. You've got a barrier between that, so that ventilation, that oxygen coming in, is not able to get to the circulation. The carbon dioxide is not able to get into the alveoli to go out because there's a wall there, a wall of water or whatever.
Which then produces your arrest.
Your mismatch. It produces your arrest, and it produces that whole mismatch.
Right. So this mismatch is an important component when we start talking about cardiac arrest management,
Right.
and we start addressing reversible causes. It's not so much just here's a hypoxic patient that arrested. It's here's this mismatched patient,
Yes.
and that takes more than just filling it with oxygen.
Yes.
So
Yeah, because I could dump all the oxygen I want. I 100 liters per minute. FiO2 of 100%. Great. Still got a wall I got to get through. And until I can resolve that wall, and maybe it's with that alveolar recruitment of increasing your PEEP, that now I've kind of made a larger wall and maybe not as much water. Now I can get some ventilation and circulation exchange. But it's just, drowning, that's a foreign object that comes in. But what about the pulmonary edema patient? What about your pulmonary embolus patient? Now it's affecting a different side. So, and of course, there's always the thing, EMS is never cut and dry. So what if you have the pulmonary edema with the pulmonary embolus? What do you do then? And so all of that is to say is, the VQ mismatch relies heavily on PEEP. It also relies heavily on circulation, obviously, so we can hopefully get that gas exchange. And we've also got to be able to have ventilation, which is breathing in and breathing out, getting that transfer of waste out of there. And so we have a lot of work to do in an EMS standpoint to make that happen. Suction's involved, maybe intubation, maybe, depending on the department, is it OPA, BVM? Is it an NPA? Is it a iGel? Is it a whatever else, King tube, whatever people are using? The tool's great, but I've still got to get to that alveolar wall with ventilation and get the circulation pass. So I've got to address that wall.
Absolutely. And Pete,
Did I go off on a tangent? If I
no,
did,
I
I'm
think
sorry.
that was fabulous.
Okay.
I wanted to bring in some follow-up questions, but I think you hit all the things I wanted to talk about. Because we talked about drowning being that very good classic example of a ventilation perfusion mismatch, that VQ problem. You mentioned a pulmonary embolism, which is another fantastic one because there's a physical barrier between air coming in and out of the lungs,
Right.
and the blood coming to that area that PE is just going to create dead space in the lungs. Dead space being that it's not exchanging anything.
Right.
But on both sides, there's the blood on this side, there's the air on this side, and man, they're so close.
Right.
They're
It's
close.
like I can see you through there.
right? But they're not playing. So let's take PE for a minute. Since
Okay.
we mentioned this.
Which PE? Pulmonary embolism? Or
Embolism.
Okay.
Yeah, I got you.
Pulmonary
Let's
edema.
go with an embolism, right?
All
Let's
right.
go with this obstruction. Is PEEP really going to help out a lot directly on this PE, on this amount of dead space that is now created by this insult?
So it will not help it will not help directly in that particular, wherever that blockage is, right?
Mhm.
Wherever that pulmonary embolus is, it's not going to address it. You're not, we're going to have to do other things to get that out of there, right? And this is where the mismatch comes into play because, all right, now I add PEEP. So if I'm in the left lung, I have a blockage there. I increase my PEEP, the PEEP goes to both lungs. I've increased my ability to ventilate and circulate on the right lung, so to speak. Left lung, maybe not. So there's now a mismatch because I've increased my alveolar wall. I've allowed that to happen. My circulation kind of stays the same, but now my ventilation is increased.
Mm-hmm.
So there's a mismatch on that side, but not on the other side.
Right.
So I've got to figure out, now can I keep a patient at 98, 99%? Maybe, depending on how big that embolus is. But yeah, there's definitely a mismatch there now because, and I can't do anything until I get that clot out.
We can't directly correct that mismatch. And interestingly enough, because we all love end tidal,
Right.
as you do, right? We come into end tidal and we say there's this mismatch because circulation's still happening, still producing cellular waste, which converts to CO2.
Right.
That we might expect the CO2 to be high in a pulmonary embolism because the CO2 production is happening.
Right.
But we got to remember there's that barrier that we only measure CO2 at the face
Yep.
when it comes out and it's not coming out yet. So we get a PE. We recognize it as such. The signs and symptoms are there, tachycardic, low end tidal, all these concerns. And we put them on CPAP. We give them a little bit of PEEP to help with the oxygenation. And their end tidal goes up from, say, 15 up into the mid-20s. I'm going to call that a fantastic sign. How do you feel about that?
Yeah, absolutely. I mean, I was at 15 before. So any improvement is better than no improvement.
This is true. And this is a good example of how I feel about reference ranges.
Mhm.
That we're not 35 to 45. Oh my goodness, what are we doing? Well, of course not. Healthy people
Right.
are 35 to 45, not the pulmonary embolism patient.
Right.
Right. So it's all relative. You're right. We started at 15. We got to 25. We're actually starting to eliminate some of this waste. And hopefully the oxygenation starts to go with it as well, that maybe that's coming up a little bit better to support that cellular metabolism as well. So let's kind of take that and let's talk about into the exhalation, into the waste side of things.
Okay.
Let's talk about your experience with bilevel. That we all have CPAP readily available. We hook it up to the oxygen tank, throw the mask on in the house, and then the next stage of that is actually making this a comfortable experience for the patient. So walk me through some of your experience with bilevel. What are some challenges you faced? What are some benefits you have?
So, initially, so first thing came out, CPAP. We're all excited to get CPAP. Yes, we can help that CHF patient. I'm going to push that fluid back out into the circulatory system, get it out of the lungs where it doesn't belong.
So I know most people were excited until they saw the reduction in intubation rates. I was like, I don't know that I like CPAP.
Right.
All right.
So there's that. But while we get excited about that, and I remember when I first got a brand new paramedic, like I told you, I had to read 2 textbooks, so I didn't have all the concepts down. And I'm excited, and I keep turning up. At the time, I didn't realize it was PEEP, but I keep turning it up because my numbers don't look right on the monitor, right? Again, we're getting to the reference ranges. We're getting into, are they better or worse? Nope, they're not hitting the number I need to hit, so I got to keep turning it up. And then CPAP's not working as well. Why? Because they can't breathe out. Yeah, I'm shoving all kinds of oxygen into them, but they can't get it out. So it's like, I can't breathe.
Mm-hmm.
I'm so stupid. Well, try it. Maybe I can give you a little Versed to get you relaxed. Doesn't matter. They can't breathe. Why? Because they can't exhale. So fast forward a few years when I've learned more and when I've gotten some equipment that allows me to adjust that. You know, we tell them now, put it 10 over 5, pressure support of 10, PEEP of 5, right? What does PEEP do? PEEP is keeping my alveoli open. Pressure support is just amount of it. So now I can push in, but it's going to recognize enough when I go to exhale that it's going to allow me to exhale. And I'm like, oh, yes, now I can breathe.
Right.
You know, so it's that whole, it was a game changer.
Mm-hmm.
A slight little difference, but it was a game changer.
Right. And it is, because we take the pressure support.
Mm-hmm.
Well, let's go back. Let's say we have the CPAP and this constant pressure. We put somebody on 10, 12, 15, 20.
Right.
20 a PEEP. We're like, oh, great. Those alveoli are open, man. But if we put so much pressure in there, breathing out is supposed to be the relaxing part.
Right.
It's supposed to be the muscles just coming out and squeezing the air out. But if we fill this with so much pressure that relaxing
Right.
doesn't happen, right? So granted, like looking at some of this literature, that it might take a PEEP upwards like 45 to 60 to actually inflate the alveoli. We're not going to do that. I
Right.
mean, holy cow, we don't want those kind of airway pressures. That's going to cause some
Right.
barotrauma. But if we're looking at this patient who needs a PEEP of 10 or 12, or we're flirting with 15, we need to look at some of the other stuff, right? This isn't just a PEEP only
Right.
kind of resolution at this point. But you're right. And therein comes the bi-level benefit is we do keep the PEEP, we do keep things open, but we're able to step it down. And that's the benefit of the machine. And that's
Right.
what we're going to start seeing as we go through the summer and roll in this equipment, that CPAP's great for moving somebody out of the house.
Yeah.
You're upstairs, back bedroom, down the hallway. Great. We'll get you on the CPAP, get you on the stair chair.
Right.
We'll get alveoli open and recruited. The challenge, which we'll talk about in a minute, is transferring over from one device to the next
Right.
and losing that recruitment.
And also keep in mind, your patients are never up front, right? They're
This
never
is
in the
true.
living room waiting for
This is
you.
true.
They're going to be in the most complex part of their house. You can't get the stretcher to them. You can't, you're like, oh crap, I need CPAP. Let me run back over here. They're going to be so far in the corner and you've got the longer haul and they're not going to be able to help you.
Yeah.
They can't walk because they can't breathe.
Right. So we get them out there and make it a little bit more comfortable on the machine. We set them up to be successful.
Right.
So some side notes with this, some fun questions for you. That if we take this patient, we get them on CPAP, we get them on bi-level, and they get more comfortable. End tidal comes up, oxygenation comes up, work of breathing goes down,
Right.
mental status improves, all the things we want to see.
Mhm.
Is this an emergency transport or is this a non-emergency transport?
It's funny you mentioned that because we're having a discussion about emergency transports and what qualifies that at our department right now. And so what we've come down is it the top 3? Is it time sensitive, like a heart attack where I need to get them to a cath lab?
Mm-hmm.
Is it time sensitive where it's a stroke and they need, comprehensive neurological care? Or is it time sensitive because they need a surgeon because it's trauma? Pretty much I've done everything that the ER is going to do to fix them at the front end. So I have time to relax. I have time to take care of them. So no, in my opinion, that is not emergency transport. Unless something changes en route, I've managed that patient. And I can make my tweaks as I need to make them if I need to have an adjustment on the oxygen. But that should not be a lights and sirens call.
I agree. And let's be clear, still a sick patient.
Still a sick patient.
Still very concerning.
Right.
Absolutely.
But not emergent.
Not an emergency transport.
Right.
I
Now,
agree.
not able to sit against the wall of the hospital either for more than, whatever your time frame
There may be
is.
differing opinions on the
Right.
receiving staff, but I agree with you 100% that we're able to do so many things in the field and manage so many things, and that time benefit, there's no time benefit.
Right.
And one of my things that I like throwing out there is that the back doors of the hospital are not an intervention. There's no therapeutic benefit to the back dours.
Especially when you consider how long you might be standing against a wall.
This is true. So especially when they hear that your patient's managed,
Yeah.
they're on CPAP, set them over there. You're like,
Yeah.
hey, wait a minute.
Yeah.
But, and y'all have a little bit higher capabilities, especially as we're talking about heart failure and pulmonary edema, that you need to go set this patient up on some infusions to manage some of the
Right.
hemodynamics and things like that. Y'all have these capabilities that we're looking towards in the future to get to. But that's not to say that we're enabled to manage these very well
Right.
in the circumstances we're
Yeah,
in.
no,
So,
yeah. I mean, medicines are medicines, right? I mean,
Yep.
you're going to carry stuff we don't carry. We're going to carry stuff you don't carry. It's still about patient care. It's still about if they're not breathing, we're not doing anything. We've got to help them breathe. And if you don't breathe, you die.
Yep.
I can help you breathe.
So we're talking about, it sounds like BiPAP is a fantastic thing.
I like it
CPAP's a good thing.
and has its place. Both of them have their place.
And that's exactly what I want to hear your opinion on. Is it one or the other? Is this both?
I think that's kind of a loaded question because it depends on the patient that I'm dealing with.
Mm-hmm. Just in general, in EMS in general, do we have a place for bilevel? Do we have a place for CPAP? Or do we
Absolutely.
need to be driving towards one or the other?
I think we have a place for both. And I say that because think about how many people are on CPAP at night at the
Mhm.
house, right? To help you sleep, to keep your airway open. I'm on CPAP. That's how I knew about I couldn't breathe out the first machine I got. So, but CPAP has its place. Maybe CPAP is all I need in the short run.
Mm-hmm.
Maybe calm them down. Maybe there's some anxiety kicking in, whatever. Maybe it's something a little bit worse, and now I need to transfer them over to bilevel. It's like saying, well, then just because somebody's having a respiratory problem, should they all be intubated? Well, no. Every tool for what you're dealing with. I have a box of screwdrivers at home, but they are not all the same screwdriver.
Yeah.
But they all turn a screw.
Yes.
So
I like that example.
you
I
know,
like that one. Right. And it's true. I think we got a place for both of them. Because like I said, we might need it in the house. This is our paradox in pre-hospital medicine, though, that there's all kinds of really cool procedures, interventions, and equipment. But when this patient's up 2 flights of stairs, back bedroom,
right?
behind the bed, through, or, whatever they are, because it's like every patient's God-given right to be in the most challenging spot.
Absolutely.
That we find them. And that's kind of our medical director's philosophy, is that a patient has the God-given right to have as many ailments at a time as they want.
Absolutely.
So to say purely literature is going to support bilevels better than CPAP in the long run, and here's the benefits for outcomes, and all these things are true.
Mhm.
But now we got to take another machine up the stairs, back bedroom, set this up in the house. Then we got to
Right.
move this patient. So I see this as our paradox in EMS, that we can do all of these things and we can enhance our care. How many infusions have you sped up and run in a house?
Personally, probably just one.
Right? I mean,
It's either like
that's
nitro.
not in an arrest.
It's not an arrest.
Post-arrest.
Maybe Levo. Maybe an epi drip. Maybe a nitro drip if I'm dealing with the CHF. But I'm usually not. I'm not the Lifelike transfer medic that's doing 15 drips in the house. I'm doing what I need to do to get them from that spot and not die on the way to my ambulance.
So it's more frequent that you've hit some push dose boluses of
absolutely.
medication until you get outside to infuse.
Absolutely. And my favorite, I have two favorites. Again, depending on why I'm having to do them, but I love push dose nitro and I love push dose epi, and mainly because they're just so simple.
Mm-hmm.
Push dose levo is pretty simple as well. Once you pull it up, once you know your stuff, but just to mix it and get it ready to go, it's just too easy. So
the same concept applies to the ventilator. How many times are you going to bring the ventilator in on a respiratory patient? Right.
If I know it's a respiratory patient, then yeah, I'll bring it.
Let's say it's your general difficulty breathing.
Then
Does every one of those get the ventilator in
No,
there?
absolutely not.
Right?
No.
I mean, we get our standard. You're going to bring your bag. It's going to have a BVM, your
Yep.
adjuncts in it, right? Going to have your airway stuff in there. You're going to have an O2 bottle.
Yep.
'Cause
Your
I think
basic intro medications, albuterol, Atrovent,
Right.
whatever's called for that quick intervention.
Mm-hmm.
Let me get you the truck where I can do more. That's my controlled environment. I can control everything, my temperatures, all that stuff in there, and then we can move you at a correct pace to the correct facility.
I like it. I like it. So, all in all, a place for CPAP and a place for bilevel ventilation.
I think so, yeah.
If we want to get name brand, BiPAP in there, right?
Right.
All right. So, let's see. We talked about a lot of stuff. Let's talk about one last little chunk, one last little chunk, I guess.
Mhm.
The interthoracic pressure we create with CPAP. So we fill the airway with pressure. We fill the lungs and alveoli with pressure, which then transfers outside the lungs to the thorax. And we have interthoracic pressure. There's some other mechanisms that work on this negative pressure besides the lungs.
Right.
And that's my favorite, the heart.
Heart. Yep.
Right. So let's talk a minute about CPAP doesn't exist in isolation, that we put somebody on CPAP and we dial it up to 15. What are you expecting to see in this patient's hemodynamics, or what are you at least prepared to respond to should you start seeing things in this patient?
So if we go back to my first time dealing with it, where I'm cranking it up, they can't breathe, you're putting a lot of pressure, literal pressure on that heart, and it's not going to function like it's supposed to, right?
Mm-hmm.
So I'm going to see probably, depending on how long I've got, the lower heart rate, a lower blood pressure, and if I'm dealing with a CHF patient, at first I might be thinking, oh, it's working, right?
Yeah.
Their blood pressure's coming down. Their heart rate's coming down because our 3 signs of CHF, tachycardia, tachypnea, and hypertension,
Yeah.
right? So I'm like, oh, great, it's working. But then you keep it watching, going slower and lower. And you're just like, I thought this was supposed to fix the patient, not hurt the patient. And again, it's having a grasp and an understanding of what you're doing. Because everything we do, no matter what your intervention, is going to have an effect.
Mm-hmm.
Can be positive, it could be negative, but we may not see that immediate negative. And that's why that's why continual patient management and assessment is so important. Yes, I want that blood pressure to go down. Yes, I want the heart rate to go down. But I kind of need to have in my head a reference range to say, okay, I don't want it going below here.
Mm-hmm.
And you have to decide as a medic. And I have a friend who used to always say, what's your what do they call it when a helicopter can't go any farther? Your bingo point or something?
Oh, heck, I drove trucks, man.
Whatever. You hear on the movie, bingo fuel. Hey, I can't go any further because we're not going to make it back.
Okay.
And so using that kind of thing, what's your bingo fuel moment for that patient? What's your, hey, I'm not going to let this heart rate or this blood pressure get to here because then it's going to be harder for me to get back. Do I need to make an adjustment on my PEEP? Do I need to make an adjustment on the amount of pressure I'm giving in a CPAP? And because that intervention, as great as it is going to have a negative impact on that patient's circulatory, the heart, the blood pressure, all of that. Because like you said, I'm increasing all that interthoracic pressure.
Yeah.
And it's going to make it harder. It's already hard because they're already struggling.
Mm-hmm.
And their bingo time might not be very long.
You might be past it already.
Right.
And it's very peculiar because you're right, specifically in heart failure. We're going to have another heart failure episode where we get to talk about some management there. But yeah, we want the blood pressure to come down.
Right.
But we have to understand that right side of the heart is counting on the negative pressure to suck some blood in, fill up the right ventricle, put it through the system so that the left side gets that preload. So we should anticipate this kind of reduced preload in a CPAP patient. And now if we're dealing with an acute heart failure patient where the right side is already damaged and suffering, and that's what's producing this problem to begin with, then, oh my goodness, there we go. Or if we're dealing with the left side that's actually backing it up where we're hearing all the fluid and having all the trouble, right? Yeah. It doesn't exist in isolation. So we go back to my favorite question of why. Right? We get the heart failure patient and we do want the blood pressure to come down. And it is coming down. And hey, we celebrate, we high five, nice work. But why is it coming? Is it coming down because I gave any kind of blood pressure control? Right. Did I do any kind of vasodilation? And you're right, when you didn't, and this pressure goes from 240 over 120 to 130 over 60,
right, with
no other therapy but CPAP, this should cause us some concerns.
Absolutely.
It makes me a little bit worried, right? So, so CPAP is a phenomenal tool. Doesn't exist in isolation, has this butterfly effect to the rest of the body, which really is a fun balancing act when we talk about heart failure again.
Right.
Because as the blood pressure does come down, the body's going to want to respond to that. And that's what made us hypertensive in the first place, is that the kidneys tried to help out, dumped all the hormones in there to make all this stuff happen. So they're going to start dumping more. Yep. All right. So it's going to be a fun heart failure episode when we talk about that one, right? So because we've already talked about PEEP. Yeah. So in that episode, we get to talk about a whole lot of the medication management. So as a double check some of our our last bits of note here. Man, we talk about CPAP and bilevel themselves. They're kind of lung targeted,
Mhm.
but let's not get myopic on it, right? Let's
Right.
not be tunnel visioned and focused in on that. And let's not forget that the CPAP doesn't help with the elimination.
Right.
And in fact, if we don't do what we need to enhance the ventilation to eliminate, but we're enhancing oxygenation, we may make a bigger waste problem
Oh yeah.
by giving more fuel to burn. So, some pretty interesting discussions as we talk about PEEP.
All right.
Are there any other thoughts you want to share with us about PEEP, about ventilation, knowledge you want to leave us with?
Just sometimes it's hard, I think, especially as you're starting out as a new paramedic. And of course, depending on the level of education you got, you come in and the book says this. And while that gives us a great foundation, you've got to be continually learning. You've got to be continually studying. You've got to be that lifelong learner about things, because in medicine, things change quick, right?
Mm-hmm.
And just today we had a BVM ventilator class at my department just to talk about, BVM's great, but your medical director, Dr. Humphreys, had a great talk at the Texas Cares about, hey, the size of your hands, the frequency of which you squeeze the bag, the aggressiveness, all of these things, they matter. It's kind of like words matter. These things matter, and we don't think about them on these respiratory. I need to bag the patient. Okay, here we go. Or you get that excited brand new firefighter, a brand new EMT that's never done it on a live patient before. And yeah, they're bagging great. Their O2 sat's 100%, but they're not exhaling, and they're not, there's all these things. And so you just have to make sure that you're constantly getting that baseline knowledge and that you're adding to it every single time. Much like these conversations did not happen overnight.
Mm-hmm.
A lot of it was, hey, I don't understand this. Can you help me understand it better? A lot of it was me going to YouTube and going, okay, I need to figure this out. Kevin gave me his explanation. My friend Mark gave me his explanation. I got their reasons. Now I got to find mine,
Mm-hmm.
and I've got to be able to understand it to the guy that can't understand it. Or I've got to be able to explain it to the guy that can't understand it. And so that comes. Even getting ready for this, I watched a few YouTube videos, VQ mismatch, making sure I had a full and complete understanding. Because the last thing you want to do is sound like you know what you're talking about, but you don't.
Mm-hmm.
And I'm sure when people watch this, somebody's going to go, that guy doesn't know what he's talking about.
It's cool. They do it with me all the time.
Yeah,
You're in good company.
He forgot this or he forgot that. You know what? I probably did. But based on what we were talking about today, it's
Mhm.
stuff. And I've learned some stuff today. And anytime I talk to you about the heart, I learn stuff. So, but just keep adding. That's the biggest thing. And ventilation is going to be different for every patient, whether it's a rate, whether it's tidal volume, height, body weight, ideal body weight versus actual body weight. There's all kinds of things you got to take into effect, but keep learning. That's probably my biggest thing is keep learning.
So let's close this out with recap a couple of these key points.
All right.
So PEEP, fantastic,
Mhm.
opens up the alveoli for oxygenation, but we got to be mindful of exhalation.
Yep.
As we're dealing with the ventilation circulation or VQ mismatch, that ventilation perfusion mismatch, this could be our means to do that. That if our mismatch is poor alveolar recruitment in drowning, in pulmonary edema, in pneumonia,
Right.
this could be an approach to address it. Bilevel, coming soon,
Coming soon. I like that.
will be a fantastic tool to move with and kind of make patients a little bit more comfortable.
Mhm.
And CPAP's going to have hemodynamic impacts.
Absolutely.
I'm sorry, we can't say so many absolute things. We should be prepared for hemodynamic impacts
Right.
on the CPAP patient. Right?
There's no always, there's no
You
never
know how I
in
feel about
EMS.
always and never.
Yeah.
We've talked about that. We should be prepared, right? Because it kind of goes to, I say it tongue in cheek when I say it, that patients don't suddenly deteriorate.
Right.
We just suddenly notice.
Yes. Yes.
And it's because we just don't know what we're looking for sometimes. That something happened and it's, holy cow, what a change rapidly. This is an opportunity that we should anticipate that if we get a patient whose blood pressure is starting to bottom out on CPAP, we shouldn't be surprised. In fact, we should be prepared for that.
And you should be ready to answer the question that is your favorite question.
Why did
Why?
the blood pressure go down?
Right.
So, all right. So some good key tips there. Jay, thank you so much for the time
Yeah,
and
you
the
bet.
effort to come
My
in and talk
pleasure.
about PEEP with us today.
Yeah.
So
I had a great time. I got all excited when we started talking about this. I was like,
this is why I had you. I'm excited. So thanks for listening. Hope there's some things you took away from it, and we'll see you for the next one.